Good afternoon, everybody, and good morning, depending on where you're at. My name is Charlie Ravens, and I'm with National Coalition of STD Directors, and we want to welcome you to our call today on how STD programs can increase PreP usage and facilitate STD prevention. We're really excited about today's call. We have three really excellent speakers. I think it's going to be very informative and interesting. And so we have a lot of information to get through, so we're going to go ahead and get started. As usual, our disclaimer, this NCSD is supported with funds from the Centers for Disease Control, and we greatly appreciate that funding, and that helps to fund activities like this. The views expressed by our speakers today or myself are not necessarily the views or policies of Department of Health and Human Services, nor NCSD. The facilitators for the call today are myself, Charlie Ravens. I'm a technical assistant consultant with NCSD. And we have a new staff member who we're really glad is on now, Lindsay O'Keefe, and she's going to be helping me with the call and looking at questions and those kinds of things. So hopefully we'll have no technical issues. Some of you are new to our NCSD It's Your Call format, and they're basically webinars, and we try to have some time built in for questions, both after each speaker and at the end. And kind of what we really have learned that is there's a lot of great things that are happening out in the STD programs, and we want people to be able to share and learn from each other. So we're very supportive of peer-to-peer technical assistance, both through these calls. And I'll be talking a little bit later about how you can get technical assistance either from NCSD or CDC, or we can link you up to other technical assistance providers. A couple of housekeeping things. We have muted all the phones. We expect to have a lot of people on this call, and so we will have to have the phones muted, otherwise there's too many distractions. If you have questions, you'll be able to ask them there's a chat feature on your left, and you can just write in your question, and then after each speaker, if we have time, we'll try to take questions. If not, we'll definitely do that at the end. This call is going to be recorded, and we will make a recording of this call as well as all the slides from this webinar available up on the NCSD website probably within a week of this session. So both the recording and the slides will be available for everyone. Again, if you have any questions or comments, please use the chat feature, or if you're having trouble like hearing or some other issue, you can send us a quick chat message, and Lindsay or I will hopefully pick up on that. So one of the things we like to always do is get an idea of who's on the call. So if you could take a minute and just answer this question about where do you primarily work at, whether it's a local health department, state health department, CDC, academia, or other, or not applicable. So we'll do a quick poll of our participants. And about 5 more seconds, and let's get an idea. So it looks like almost 75% of you are from a state or local health department, which is great because that's who our target is, along with community-based organizations and academia. So again, we really appreciate our participants. We try to make these programs really targeted to people who work day-to-day in programs and make them so that they're relevant and useful to you. A little bit about the agenda. I'm starting off with a really quick introduction, followed by Dr. Phillip Chan from Rhode Island, who's going to talk about how they've sort of implemented PreP, especially through their STD clinics, followed by Dr. Leandro Mena, who's going to talk from Mississippi about how they've sort of used a different model. They're primarily identifying clients for PreP in their STD clinics, but then referring them out to healthcare providers and working with the community to get healthcare providers using PreP. And then we're going to have an interesting talk by Dr. Sam Jenness, who's going to be talking about how through STD modeling we can show that by getting people who are in PreP and getting them screened more frequently for STDs and getting them treated if need be, we can actually PreP and getting people screened can actually help reduce STD prevalence. So I think there are a lot of benefits to using PreP. NCSD supports PreP and encourages our members to have a role, and we feel that everybody has a role in PreP, whether you can actually provide it in your STD clinics or whether you can educate and refer people. So we think there's a big role for PreP, and it's an important strategy in both not only HIV prevention as well as STD prevention. So in thinking about this and preparing for this, we had some questions for our presenters, and we wanted them to talk about things like what are some things that programs can do to foster PreP usage and increase uptake by clients. Not every program has the resources to be able to purchase medications and provide PreP in their STD clinics, or a lot of programs don't have STD clinics. But we feel like every program really has a role in helping people contribute to the PreP uptake cascade. Again, how increasing the frequency of STD screening among MSM on PreP as well as MSM in any clients can reduce STD prevalence. Another big issue is condom usage. I think sometimes we have a sort of a one-size-fits-all message with condom usage, but I think sometimes we need to tailor it. I think hopefully our speakers will sort of talk about what kind of condom messages should you give to what kind of clients. If we have a chance, hopefully some might address some of the factors that might be contributing to an increase in STDs among MSM. Is it PreP related, or is it other factors? And possibly some suggestions for protocols and plans that might help people at the state and local level. So without further ado, I'm going to turn it over to our first speaker, Dr. Phil Chan, and just a little bit of background about Dr. Chan. He's an assistant professor in the Department of Medicine at Brown University and a physician in HIV and infectious diseases at the Miriam Hospital Immunology Center in Providence. He is the director of the Rhode Island STD Clinic, and he also runs the pre-exposure prophylaxis program at the clinic. He's a consultant medical director for the Rhode Island Department of Health Center for HIV/AIDS, viral hepatitis, STDs, and TB. And he's working with the Department of Health and other community organizations on several statewide initiatives. So, Dr. Chan, turning it over to you.
Great. Thank you so much, Charlie, and good afternoon, everyone. It's a pleasure to be here. Next slide, please. So just a little background about our STD clinic in Rhode Island. So Rhode Island, the largest city in Rhode Island is Providence, the capital. We see about 80 to 85% of all HIV and STD cases located in and around Providence. So essentially, it's the major urban center there in Rhode Island. Up until 2011, there was no STD clinic present in Rhode Island, and we actually opened up a first clinic in January of 2012. So as far as STD clinics and programs go, it's relatively new. We've seen an exponential increase. It's a collaboration between our Rhode Island Department of Health, who supports it through some money for staff, as well as our local Brown-affiliated hospital, the Miriam Hospital, which is also the site of the largest HIV clinic. We opened the clinic in January 2012, and initially we were testing a couple hundred people a year, so not that many. We're now on pace to test over 3,000 people a year. So it's really exponentially increased since 2012, and we've pretty much plateaued out at that point. We are only open three half days a week, Wednesday, Thursday, Friday afternoon. But our STD clinic really built off our community initiatives to really focus on gay, bisexual, and other men who have sex with men. In fact, about a third of our clinic clientele are MSM and specifically come in for testing. We do offer the option, happy to talk about this more some other time, but we do help offset the cost of testing, meaning that for people that have insurance and are willing to use it, we definitely bill insurance. But we also have a safety net option for people that are uninsured or for people that don't feel comfortable using their insurance or want to remain anonymous. In that case, the hospital has generously agreed to cover the cost of testing, so we're able to make it very accessible and for people that are uninsured. Next slide, please. So PreP was approved in the summer of 2012 In 2013, we started a PreP implementation program here at our STD clinic. And what that looked like was that we started to educate all MSM who came through the door of our STD clinic. So that was the first important decision that we came to, was the fact that we weren't necessarily stratifying or identifying specifically high-risk behaviors among MSM. We made the decision early on that we were just going to educate everyone who walked through, all MSM who walked through the door, about PreP. And the reason why we did that is in early 2013, of course, PreP awareness in general was very low. So we decided that we just wanted to educate the community at large, and that regardless of whether or not someone met clinical indications for PreP, it was good for them to know about it, and of course they would have friends that may qualify for PreP. So we just started educating all MSM who came through the door. We started offering basically a 5-minute educational session based on this one-page sheet that you see here. If anyone wants this sheet, I'm happy to send it around in Word, in a Word document, but it's based on basically the CDC guidelines, preliminary guidelines at the time. And as you can see, it just basically goes over what PreP is and some of the major questions that people have. It provides a follow-up number where people can call. And the goal was that all staff at the STD clinic would provide this brief educational counseling session to MSM during the time period that we were offering and waiting for the rapid HIV test. So we would do the OraSure or quick rapid HIV test. We would have 20 minutes downtime. Part of that session was basic education counseling, and then 5+ minutes as needed was dedicated to PreP education. Next slide, please. For people that were interested in PreP, and after the educational session, we did have a one-page assessment form. I'm going to go over with some of this data today. Basically, for everyone that we educated, we asked them if they would like to follow up with a doctor for PreP. That's one thing about our program, is that we do not provide same-day PreP prescriptions, and I realize that's a barrier. It's something we've talked about, but at the current moment, we don't have enough staffing needs to provide PreP the same day on site. So for people that are interested in PreP, they at the same site, they make a medical appointment for a future week or two to actually get on PreP. This is the form that people fill out. It allows us to actually see why people are not getting on PreP. And you can see down at the bottom that if they're interested, we ask for their contact information so that we can call them to make an appointment. Next slide, please. So for the first couple of years from 2013 to 2015, we actually monitored how many people were getting educated and how many people were actually getting on PreP. I just wanted to show this. This is one of the hotter things. I'll talk about this a little bit later briefly, but thinking about this in terms of a cascade. So out of the first couple hundred, 234 MSM that we educated the first couple of years, you can see that about 11% actually ended up initiating PreP. And that seems really low, but this has been actually replicated at a number of other sites, including some STD clinics in the Midwest. There was something presented at the CDC HIV Prevention conference about a year ago. And this is also the same sort of cascade that we've seen at other programs and other public health programs, such as Washington State. They've also presented some data about PreP outreach within their partner notification programs, and shown that PreP uptake through people referred through that mechanism tends to be about 10 or 11%. And you can see that there's drop-off at every way, and we're in the process still of exploring some of the reasons for this, but you can see that there's been significant barriers for these guys getting on PreP. Next slide, please. When we started, we did take a deep dive in terms of doing some statistical regression analysis looking at risk factors. And one thing that we found at our STD clinic, was surprising, was that risk perception has really been one of the main drivers of people getting on PreP. In fact, when we looked at all the demographics and behaviors that we can collect, really the two things that fell out was that if you had an HIV positive partner, you were more likely to get on PreP. And that if you thought your risk of HIV was higher, you were also more likely to get on PreP. And so this makes sense. And looking through the literature and thinking about reasons just for HIV prevention in general, in terms of why people do or do not get HIV tested, for example, risk perception has been one of those things that has been a significant barrier in terms of people engaging in prevention services. Next slide, please. These are the two questions on our intake form that we do ask. We've been asking these questions actually since 2012 if people had heard about PrEP or PEP as well, and if they'd taken PrEP. Next slide, please. So one thing that we analyzed was one thing that I firmly believe in is evaluation and monitoring. And one thing that we looked at, or we wanted to look at, was how much of an effect this very brief educational intervention had on PrEP awareness and uptake in our clinic. And so we did an analysis, and I'll show you the results in a second, but the first thing that we found was that for people coming in general, I'll draw your attention to race and ethnicity, is that African-American, non-Hispanic African-Americans had a significantly reduced awareness of PrEP. So black African-Americans had about a 26% less awareness about PrEP. In terms of age groups, the other thing that fell out was that those of younger age groups, specifically 20s or 30s, had a significantly higher chance of being aware of PrEP. Next slide, please. We also did an analysis, and this is a little bit of a complicated analysis, but it was called a differences in differences approach. And basically what we looked at was people coming in before they were educated about PrEP, and looking at the group of people the group of MSM who had come in at least 2 times. And so what we wanted to know in this group of people that had come in 2 times is if they had come in the first time and received the educational intervention, were they more likely to be aware of PrEP the second time? And importantly, were they more likely to be on PrEP the second time? And so we compared 2 groups. We compared the group of people who had come in multiple times before we had done the educational intervention, and then we looked at people after the fact when we had rolled out the educational intervention to see if it had improved education and use. And I'll draw your attention to the third line here that says treatment group second visit. And what the slide shows basically is that for people that came in for the second visit, they had a 19 percentage point increase in that group of being aware about PrEP compared to people that hadn't had the intervention. So this is saying that 19%, so there's a 19% significant increase in people who are aware of PrEP just based on an intervention. And then in the second column set, you can see that there's a 4% percentage point increase in PrEP use among this population. And this certainly doesn't seem to be like an incredibly high effect, but if you look at the relative percent increase, this is actually equivalent to a 47% overall increase in PrEP awareness and a 133% increase in PrEP use. Next slide, please. And so let me show you what this looks like. So if we look at before the point where we implemented our intervention, which is that gray dotted line there, this is sort of the baseline PrEP awareness. Next slide, please. You can see in our treatment group, so these are people that have, before they got the PrEP intervention, but they did get the PrEP intervention eventually, you can see that PrEP awareness in general is increasing in the community. And I thought this was really cool. This sort of is the background PrEP awareness that is increasing over time in our MSM population coming into our STD clinic. Next slide, please. If you then look at the control group, this is the second visit of people that had not had the educational intervention. You can see it pretty well matches the treatment group there for visit 1. These are people on the first visit for people 1 in that red dotted line who had not been educated yet about PrEP. Next slide. You can see here in the red straight line, this is the second visit for people that had been educated about PrEP. So you can see in these people that had come in and received the educational intervention, they were significantly more likely to be aware about PrEP compared to the people that had not had it. And so this was sort of what's known as a quasi-experimental approach. It showed that we were effective in increasing PrEP awareness among our population. Similarly, these results are a little bit less robust, but we looked at PrEP use. You can see the same basic concepts here. These are people that had not received the intervention. Next slide. And then you can see for people that had been educated about PrEP, they were more likely, significantly more likely to actually be on PrEP. So these two results here, this sort of study really demonstrated that we believe our educational intervention, this brief educational intervention or STD clinic, was effective, especially for increasing awareness in our population, as well as increasing in use. And Dr. Mena can comment on this too, but one thing that we do find is that sometimes it takes time for people to actually get on PreP, meaning that they'll hear about it, they've heard about it before, they've thought about it, they've talked to their friends about it, and sometimes it just takes a period of time for them to get on PreP. A couple of things that we're currently working on in the setting of our STD care. We are specifically working on defining and evaluating the PreP care continuum. So similarly to the HIV care continuum, PreP care continuums are and have been defined. One thing that still remains largely unknown really is the goals of PreP care. So what is the end point of the continuum? So what I mean by that basically is that in terms of the HIV care continuum, obviously the endpoint is viral suppression, and it should be, and that makes sense, and everyone that has HIV should be virally suppressed. In terms of the PreP care continuum, it's unclear at this moment what the true outcomes of the cascade are, meaning that not everyone that initiates PreP today is really going to be indicated for it at 3, 6, 12 months. There's people that are coming in and out of monogamous relationships. There's people that may be coming abstinent or not having sex for another reason. So we don't have a good sense about sort of the true denominator and our endpoints in thinking about the care continuum. Certainly for people that are indicated for PreP and prescribed PreP, adherence and retention in care are the key indicators. But we're still, I think, as a public health community, a clinical community, trying to figure out what our appropriate endpoints and goals of the continuum are. Next slide, please. I will also mention that we, to go to the point of looking at behavioral changes among MSM, this is a paper that we just published last month, actually. I encourage the references down below here. But looking at what behaviors have changed among people on PreP. So the two main behavioral changes that are often cited are either a decrease in condom use or an increase in the number of partners. We looked at both for this study for people that had been on for 3 and 6 months. And what we basically found was that there are no difference in total number of partners, but there was a significant decrease in condom use over 6 months. Again, this was following a longitudinal cohort. There were only 61 people in this cohort over 6 months, so a pretty small sample size. But basically the word on the street, and it'd be interesting to see what Dr. Mena thinks, but the word on the street that we've been hearing up here is that people are using condoms less likely. They're not necessarily going out and having a whole lot more sex, but they are definitely, a subset certainly, are using condoms less likely. Although this is a little bit difficult to quantify in that people may not always be reporting 100% of their behaviors up front. So when they first come and see you, they may be telling you initially that they're using condoms all the time, and then when you see them and build that rapport at 3 and 6 months, they may be finally coming, telling you the truth versus actually changing their behavior. So some of that may be a little bit tough to tease out, but based on our reported data, and we think we have a pretty good handle on this, and based on the word on the street and qualitative interviews, it does seem like there is a little bit of a decrease in condom use. Next slide, please. Finally, just in terms of how we put PreP together with how we market it in our community, we came up with a campaign for Rhode Island called Do It Right. The highlighted RI you can see stands for Rhode Island. But we really do market PreP as a combination HIV prevention approach. We recognize that a lot of people may want to do different things for prevention. That PreP is certainly one option. We encourage condoms, but we do not push them aggressively in terms of saying for people who present on PreP that you need to use condoms 100% of the time. We have a risk and benefit conversation. We try to be realistic. We try to have a harm reduction. And we do encourage condom use and provide them for free, and certainly mention that PreP is not effective in preventing other STDs. But I feel like by pushing condoms too hard, it has turned some of our patients off. So we're very careful and try to strike that balance, because in my belief too, PreP is frankly perfect for people that never use condoms. So I think we don't want to be judgmental and turn people away who never use condoms. but we want to encourage especially those people that PreP is another option. We need to be very careful and aggressive about screening for STDs. But in my opinion, PreP is really perfect for the people that have less than 100% condom use. Next slide, please. So I'm happy to send any articles or any of the material we use in our STD clinic, and happy to answer any questions after the other speakers. Thank you.
So in the interest of time, I think we're going to go ahead into the next speaker. Feel free to, if you have questions for Dr. Chan or any of our other speakers, send them in the chat, so we'll all be ready to ask questions. And so just a second about our next speaker, Dr. Leandro Mena from Mississippi, and a few things from his bio sketch. He's a professor and chair of the School of Population. More than 14 years of experience in clinical and epi research in the area of STD infection and HIV. He's the medical director of the Crossroads Clinic in Jackson, Mississippi. He's dedicated a significant proportion of his efforts to development, implementation, and evaluation of models to provide culturally competent HIV services to MSM of color. So again, you can read extensive biography when you get our slides, but without further ado, let me turn it over to Dr. Mena.
Well, thanks, Charlie. Very happy to be here. So what we're going to do today briefly is about how we were able to implement, a pre-special prophylaxis program in an STD clinic that, different to the model that Dr. Chan presented, was not able, to have the PreP clinic within, the clinic. So, many of you may know, Mississippi and certainly Jackson have probably among the highest rates of STDs, of HIV among men versus men. Some estimates say that it's about 40% of all men versus men are HIV infected or were HIV infected by 2014. And the HIV incidence among men versus men has been estimated to be around 4%, and perhaps, around 7% among young black men versus men. So next slide, please. So our STD clinic is centrally located in Jackson. It's a public health clinic, receives 100% fairly funded, and next slide, serves about 10,000, unique patients that with about 20 to 22,000, visits per year. As you can see here, the largest proportion of the population that we see are African American, almost 50-50 female and male, but about 1/3 of all the men who come to the clinic report having sex with other men, and 75% of all men versus men coming to the clinic are black men aged 13 to 29 years old. So if you see, as you can see in the chart, 50% of our patients are between the ages of 18 to 27, and 78% are younger than 36. So we serve most typical STD clinics, a very young population. What's not necessarily typical of the prototype STD clinic is that we really see a large population of gender and sexual minorities in the clinic. And if you see, while the HIV seropositivity rate for the clinic is about 1.9%, among young black men versus men is 11.9%. So no doubt, that there was a need for urgent, access to PreP once pre-exposure prophylaxis became available. But for a number of reasons, that are, I think, very common to many health departments that have to do with funding and the structure that prevents, from implementing PreP within the space. That was not possible. One of the things that we recognized early on that could be a potential barrier, for accessing PreP was the perception of risk. And just like Dr. Chan presented, where uptake for PreP was higher in those individuals who saw themselves at higher risk, we felt that in our population, one of the major barriers that we have is that many of our patients, regardless of the behavior that they report, may not necessarily identify themselves as risk. But we also felt that in our clinic, not only the patients, but also the staff didn't necessarily identify, the staff was already taking care of such a high-risk population that they really were not being able to identify individuals at risk but only, recognizing risk where individuals were extremely high risk. So we actually use the tool for risk certification for MSM that is available with the PreP guidelines and was done by Don Smith. Primarily not because we really care much about the score at the end of the day, but because it helped to allow a conversation around risk between the patient and the provider, creating the relevance of why the information about pre-exposure prophylaxis was important. So in the STD clinic, we in mid-2013 we implemented a program of educating all men who have with men about pre-exposure prophylaxis. And we created, next slide please, a flyer that you can see. It's hard to see, but again, happy to send the Word copies of each one or PDF copies of each one of these things, similar to what Dr. Chan presented, kind of educating all patients about pre-exposure prophylaxis. We developed the flyers, and but we also work on educating, healthcare providers in the area, so they will, help to identify individuals who can benefit from PreP and that could be referred to our PreP clinic. We educated, other healthcare professionals that were working with individuals who are at risk of HIV, that included youth health services, included mental health services, substance abuse treaters, and HIV advocates and advocates. We also work with the STD clinic staff and disease intervention specialists in doing both PreP education and also cultural sensitive training, so they could approach the conversation about health in a sex positive approach. And finally, we partner with some of the local community-based organizations providing education to consumers. The health department, while they were not able to set up to help us with the setting of the PreP clinic within the health department, they actually contracted with the American Sexual Health Association to establish a 1-800-YES-PreP line where consumers were able to call. They will get triage based on information that they gave, and they will be referred for PreP to a PreP provider, to the closest PreP provider, based on their zip code. As you see here, these are some of the examples of push cards that Asha developed for us. We made with this social media post. We create a wristband with the phone number for the PreP line that we gave at the STD clinic for every person who got tested for HIV. So what we were able to do, next slide, was actually to have a partnership with a local community-based organization that had opened a clinic, a primary care clinic, community clinic, in early 2013, that had as a mission to provide primary care with an emphasis on the health needs of lesbian, gay, bisexual, and transgender patients. So one of the goals of that clinic was actually to bring men with men for HIV screening and keep HIV and STD screening and keep them on a rotation that every 3 to 4 months, but also with a philosophical approach of developing a partnership with the individual to help manage the HIV prevention risk. So when PreP was available, and in collaboration with Dr. Chan, we were able to get a little bit of funding to do an evaluation of our PreP program. We're able to hire a PreP navigator that helped our patients to overcome many of their barriers, financial barriers, and assistance barriers to access PreP. As you can see here, again, next slide, we develop a referral system with collaboration from the STD clinic, from existing post-exposure prophylaxis programs. We talked to 2 emergency departments that were doing, PEP, and we asked them to refer those patients, to us. We talked to a number of outpatient doctors and community clinics that were serving a high number of African Americans in our city. We partnered with research studies that were focused on high-risk MSM or HIV, studies. And then there was a lot of promotion, through friends and patients that presented themselves, because they saw some of our social media postings. So at the end, almost still today, I mean, that was in 2014, about 50% of all the patients that we receive in our PreP clinic right now at Open Arms come from the STD clinic. So in the STD clinic, next slide, please. At the STD clinic, we have developed a protocol where all patients, are screened for risk behaviors. For men who have men, we do the HIV and STD testing, and for all men who have men, we do a discussion about PreP and education about PreP. So what we started at the beginning is that we will give them the information where they could go or call for a PreP appointment, and that didn't work really well. At the beginning, probably less than 5% of the people that we identify as high risk were actually making an appointment for PreP. And what we did is that in the risk stratification form, after we have the risk discussion, we will immediately ask them, are you interested in a PreP appointment? And if they say yes, we say, well, can we give your number to the clinic so they can call you? And so we will get the telephone number. We also ask them, would you be interested to be contacted with more information about PreP? And again, they provided the information. So what we did is that then we provided that information to the clinic. So the navigators in the clinic will call the patient, taking away, again, trying not to add any burden to the STD clinic staff, but making sure that that someone will follow up with those patients and making the appointment. By doing that, we were able to increase the follow-up appointments from about 5% to about 15 to 20%. Nevertheless, we're still, losing about 80% of the patients who meet, risk criteria for pre-exposure prophylaxis, and in part, we believe it's because of the issue around having to be referred to a different center. What we have in Open Arms, once the patient shows up, is that they get their first PreP appointment, they have the clinical evaluation, and then the follow-ups for pre-exposure prophylaxis. But at Open Arms, we also test, patients for HIV and STDs, so it also operates as a default STD clinic where patients can have an express STD HIV visit without a clinical assessment. And what we have found that if PreP is offered right there on site, the acceptance rate is about 80%. So right now, less than 20% of the patients who are eligible for pre-exposure prophylaxis based on risk in our clinic who are offered PreP at Open Arms decline, a PreP, making the case, for, trying to figure out how to offer PreP at the same site. So this slide is just here to kind of show how since January 2014, when we officially started our pre-exposure prophylaxis program, to now, we have started about 250, a little over 250 patients through March 2017. Our overall retention rates are close to 75%, but we know that African Americans, patients who are younger than 25 years old, and those who are uninsured have a much lower retention rate than the rest of the group. If you see this map, I mean, the bottom, the red dot in the center is where Jackson, Mississippi is. So you see patients coming from driving, pretty long distance in our state to get access to pre-exposure prophylaxis. Some of our patients, come from as far as Mobile, Alabama, that is not included in the map, or East Monroe, Louisiana, that is probably about 3 hours away from Jackson. Yeah. So I think, that's pretty much what I had to say, and looking forward for any questions.
So again, thank you, Dr. Mena. We're going to probably, just so we can get through all our speakers, and we'll have time for questions at the end. Again, as you're thinking of questions, feel free to enter them on the chat line. If for some reason we can't get to that question, we can ask it our speaker, and we'll get back to you. The other thing is I would ask our speaker, since you've had some really great materials that you could maybe share with our participants, such as the risk tool and the flyer for clients, if our speakers would send those to me at NCSD sometime probably within the next week after this webinar, we can mail them out to all the participants since we have everybody's email for the registration process. So, before we go on to our last speaker, we want to do a quick poll to see where, if you work in an STD program, what what sort of PreP activities is your clinic currently doing? If they are you on the planning stage or you haven't quite gotten there yet? So if you could take a second to fill out this quick poll, and we'll move on and we'll see where people are at, and then we'll go on to our last speaker. So we'll open it up for about 5 more seconds. So it looks like about maybe 50, 60% of clinics, over 60% of programs are either providing PreP in their clinics or referring. So that's really great. And then another 6 or 7% are in the planning stage. So I think, we've made real good progress. We know it's not always difficult to get the resources and the training. And I think toward the end of the session, we're going to talk about some technical assistance availabilities. If your program needs some technical assistance related to PreP, how NCSD and CDC and other capacity building providers can help you out. So I'm going to move on to our next speaker in a second, Dr. Samuel Jenness from Georgia, and just a little bit about his background. He's an assistant professor in the Department of Epidemiology at the Rollins School of Public Health at Emory. He's the principal investigator of the Epi Model Research Lab, where his research focuses on developing the methods and software tools for mathematical modeling of infectious diseases over complex dynamic contact networks. So without further ado, let me turn it over to Dr. Jenness.
Thanks, Charlie, for the opportunity to present. My presentation is going to focus on a recent study that we just completed that was presented at the CROI study this year, and was just actually yesterday accepted as a journal article in Clinical Infectious Diseases. So this is going to be coming out in print in a few weeks. Next slide. So the underlying problem that this study is attacking is to try to forecast or predict where the rates of STIs are going as the scale-up of PreP continues among MSM in the United States. We know from surveillance data that rates of bacterial STIs such as syphilis are either steady or increasing. PreP protects against HIV, but not other STIs. And there's been some evidence both in terms of the demonstration projects for PreP and other behavioral studies, such as the one presented by Dr. Chan, that there has been behavioral risk compensation whereby men are reducing their use of condoms and other prevention tools that would protect against STIs. Next slide. So the causal question is really whether the increasing use of PreP is going to lead to spikes in STI rates. So one recent meta-analysis that was published in the journal AIDS by Kojima et al. At UCLA compared cohorts of MSM who were using PreP versus other cohorts that were not using PreP, and found that the relative incidence rate ratio for PreP users was between 11 and 45 times higher in the PreP versus the non-PreP cohorts. So there could be a number of different potential explanations why that was different, including the fact that the underlying populations of MSM in the PreP cohorts were just at higher risk to begin with compared to the non-PreP cohorts. But the causal question is whether the use of PreP contributed to that increased STI risk. Next slide. So that's going to depend in part on which MSM are using PreP. And so the CDC PreP guidelines provide one set of indications for clinicians who are interviewing their clients about potential PreP use, and those indications focus on unprotected anal intercourse in various partnership configurations that are listed here. So there are 3 different behavioral configurations that would indicate a men for PreP, as well as having a recent STI diagnosis. These are all supposed to be evaluated over the past 6 months, and then if any of these indications are present, then the patient is a good potential candidate for PreP. Another part of the guidelines for active PreP users is that clinicians should be screening and treating for bacterial STIs, syphilis, gonorrhea, and chlamydia every 6 months after PreP use starts. Next slide. So one of the questions about how this is going to impact STIs on the other side is this potential increase in STI screening and treatment for high-risk men could actually lead to declines in STI incidence. Stephanie Cohen and others at UCSF found that even the biannual, 6-monthly STI screening is still missing a large fraction of the STIs in MSM compared to a screening program that would be conducted quarterly. So there are ongoing questions about how to optimize the CDC guidelines with respect to this STI screening. Next slide. So the aims of our study were to use a mathematical model for transmission of both HIV as well as urogenital and rectal gonorrhea and chlamydia among MSM in the United States to, number one, investigate whether there was any support for this causal hypothesis that PreP is actually increasing STI rates, and number two, how we can reevaluate the CDC's PreP guidance related to STI screening and treatment. Next slide. So we used a fancy network model to do this, where we pull in behavioral and clinical data from a large set of local and national studies. We fit this into a big model, and we simulate the population of adult MSM in the U.S. over a 10-year time span. So in contrast to the previous two presentations, this is really forward-looking. So this is extending a model that we published last year in the Journal of Infectious Diseases, where we were just looking at HIV only. Next slide. And here are a couple more details about the methods of how we're actually doing the simulation, both of the transmission contacts as well as the underlying HIV epidemiology. So I'll skip over that in the sake of time. Next slide. We simulated the initiation and adherence onto PreP based on having an indication for PreP within a recent time frame, and then there was a fixed coverage threshold of 40% of eligible men who started PreP. We used adherence data from the open label PreP demonstration projects to simulate different levels of adherence to HIV PreP, and then men were discontinued from PreP if at a yearly follow-up visit they were no longer behaviorally indicated. Next slide. So on top of all of that, we then simulated the transmission, treatment, and recovery processes for urogenital and rectal gonorrhea and chlamydia that were varied by receptive versus insertive anal intercourse act. There were differences in the transmission probabilities by site, whether disease symptoms were associated with the infection, and then the underlying treatment probability was a function of whether the infection was symptomatic or asymptomatic. Men who are on PreP could vary different levels of condom-related risk compensation, where at one extreme they didn't change their behavior at all, and at the other they completely replaced condoms. Next slide. So here are the results. So in the baseline model for both gonorrhea and chlamydia, the base model in which no PreP was present, the incidence rates for gonorrhea were 4.4 and for chlamydia were 6.8. After PreP coverage, the rates of those STI infections is predicted to decrease substantially by over half. If we look at it in terms of cumulative incidence, we might be able to prevent between 40 and 42% of new infections, even assuming that there was a 40% level of risk compensation. Next slide. So here's looking at the same results, but the interaction between risk compensation and coverage. So basically, at every level below the the deep purple in the upper left-hand side of both infections, there's a net prevention benefit for scaling up PreP in terms of STI incidence. So the levels of risk compensation would have to be extremely high, higher than we've observed in any empirical data, and the PreP coverage levels would have to be quite low to lead to an overall increase in STI incidence. Next slide. The reasons for this prevention are not because PreP has some sort of biological effect on these bacterial STIs, but because we would be capturing under the broader screening and treatment program for PreP users a significant fraction of asymptomatic and rectal infections for for gonorrhea and chlamydia, more so than we would be capturing outside of a PreP screening program. And so the highlighted box there is showing you the reference scenario under which we're tracking the number of infections we're predicted to treat. Next slide. It's a little easier to visualize this, with a plot where these lines are showing both on the left and the right the incidence rate curves over the next 10 years. So the plot on the left is showing how the incidence rate of these STIs is going to vary based on the screening and treatment interval for the infection. So the base scenario is that middle line for 6 months screening and treatment. And so we're predicted to drop the incidence of the STIs lower over time based on that, but we can make an even bigger impact if that screening interval is dropped down to 3 months. On the right-hand side, this is just showing you evidence that if we're not conducting the screening or treatment at all, and so that's the proportion treated, or if there's a significant rate of treatment failure, the risk compensation is going to simply overwhelm the impact of this increased screening in the population, and could, if fewer than 50% of patients are screened and treated on a 6-month interval, lead to increases in STI incidence. So it's critical to perform the STI screening and treatment for PreP users. Last slide. So in conclusion, in this study, we found that HIV PreP could result in a significant decline in STI incidence among MSM in the United States, and that's entirely attributable to the recommended screening and treatment for STIs that are within the CDC PreP guidelines. HIV PreP should be marketed and provided as a combination HIV and STI prevention package, not just the doling out the medication to patients. MSM who are indicated for HIV PreP are also at substantial risk for STIs too, through the same sexual partnership networks and the same behaviors. So with respect to the causal question, we found no evidence that risk compensation could reproduce the sort of STI rate differential that was suggested within the Kojima meta-analysis, suggesting that instead there might be selection biases and other non-causal effects that were driving the differences when comparing the cohorts. And then finally, reducing the STI screening interval from every 6 months to quarterly could further reduce the incidence of these STIs, although there are certainly some complex cost implications for doubling the amount of screening and treatment involved. Thanks very much.
So thanks, Sam. We really appreciate all our speakers. Go ahead, if you have any questions, put them in the chat box, and we'll get those lined up, and we'll ask those in a minute. A couple of things we want to just finish up with before we go to the questions is, first of all, if you have more in-depth questions or want to talk to any of our presenters, here are their emails. Again, we will be posting this information, so if you don't have time to write it down now, we will be making these slides available. Another thing is, one of the purposes of these calls is not only provide a lot of information, but also to be able to help link you up with technical information. So if you do need technical assistance related to PreP, if you could sort of give us an idea of, do you need help in developing policies, training, funding, or you don't work in a program? So we'll just kind of get an idea real quick for our participants on what are the sort of TA needs are. And we'll close in about 5 seconds. So it looks about a quarter of you, a little bit, almost a third, need some help with policies, some training, obviously a third with funding. So if you do have any technical assistance needs, we're going to talk now about where you can get technical assistance. From NCSD, we can provide technical assistance not only with PreP, but with other issues. If it's programmatic, you can send me an email. We have our policy staff if it's related to policies and procedures related to PreP or any kind of STD prevention activity. Our policy staff, we have a specialist in adolescent sexual health who's working with a lot of the school health programs that can link you up, especially targeting adolescents. And then we have somebody working on health equity. So obviously, NCSD is a big TA provider, as well as traditionally CDC, especially for APS-funded grantees, can provide technical assistance or link you up to a capacity-building provider. So you can either email Dane Collins at that address, or they have another TA kind of or assistance email address at this ST Apps number. So again, these slides will be available where you can see that. Before we get to questions, one last thing. We are going to have a little bit more extensive evaluation of this session, but if people could just give us a quick idea whether this program today was useful and worth their time, whether you agree or disagree, and let us know. We'll give you about 5 more seconds. So almost everybody said this was either very useful or useful. So we're really glad to see that this call people felt it was helpful. A couple of questions. So here's some questions, and I'll just open these up and any of our speakers can address them. So the first question is, can you speak to some of the challenges faced, if any, with the actual implementation in the STD clinic, such as medical record system modification, protocol development, cost of PreP for patients, et cetera?
So this is Phillip Chan from Rhode Island. I'll answer that first, and it'll be interesting to hear Leandro respond to this from Mississippi. But Rhode Island is a Medicaid expansion state, and in fact, we have less than 5% of the population uninsured. So most of the people in Rhode Island are insured. So it hasn't been a problem in terms of paying for PreP or obtaining for PreP. I do have a couple people that are undocumented individuals who we apply through the Gilead Medication Assistance Program to get PreP through that. But our protocols and policies are largely just based on the CDC. We didn't talk about that much today, but just the CDC guidelines pretty much lay that out pretty clearly, 3-month follow-up, what labs to check. So we pretty much use that as a basis for our policies. And in terms of attaining PreP and cost, it hasn't been a big deal. The other thing I'll point out is that the manufacturer of PreP also has a copay assistance program. So people in general aren't paying for the medicine out of pocket. Their biggest copays and deductibles we found are actually for the medical provider time, paying for labs and paying for the cost of the actual medical visit. But the cost of the medicine has largely not been a barrier at all.
Yeah,
Leandro, any comments?
Yeah, absolutely. I think that the implementation of PreP doesn't have to be, expensive, and I think the main issue is starting. I mean, if you remember the slide that Phil presented where he showed the cascade, only 11%, 10% of people who get educated will eventually start from PreP. If you think about the data that I presented, where I have, about 10,000 patients, and only 15% are young black MSM, and 75% of those meet the risk criteria for pre-exposure prophylaxis. At the end of the day, 10% of that comes down to about 70 to 100 people. So think about what would be the cost to give pre-exposure prophylaxis to 100 people. So if you remove the cost of the medication, which will be provided by the insurance company, with copayment, with probably no out-of-pocket cost to the patient, or for people who are uninsured through the medication assistance program, the main cost comes down to the cost of the creatinine and the HIV test that is done routinely in the clinic, for which probably there are some fundings already available, and the creatinine that if you check with your public health lab can be done for less than $5. We know from our surveys that patients, are willing to pay, for pre-exposure prophylaxis, they're willing to pay anywhere between $10 to $20. So, I mean, it's not a lot, but if that's what you need to cover, you can cover it. The other cost that is there is a one-time cost, which is the hepatitis B status that is recommended. So because tenofovir and emtricitabine, can also suppress the hepatitis B, you want to make sure that if you're giving this for patients who have chronic Hep B, the patient is aware of taking the medication because he can have some consequence when you stop the medication. So that's a one-time cost. The test costs about $26. But in Mississippi, what we do at Open Arms is that we have access to the immunization registry of the state. So we first look there, and if the patient has history of immunization for hepatitis B, we don't check the surface antigen, saving ourselves, the $26. So I am convinced that, again, if an STD clinic, you don't have to be worried about the cost of the provider because we're already seeing those patients for STDs and HIV screening. That with $1,000, you can actually give pre-exposure prophylaxis, to 100 patients for 1 year. So I think it's a lot more of the willingness to kind of figure out a way to make it work than the actual, true financial cost of pre-exposure prophylaxis in the context of the services that are already being provided in the typical STD clinic.
Okay, and we have another question. Do any of the presenters have experience in providing PreP for youth under 18 years of age? Do you require a consent form, et cetera? So any kind of disclosures or insurance issues that you've experienced?
I can start, yeah. Pre-exposure PreP, Truvada is not FDA approved for minors who are younger than 18 years old. Nevertheless, as clinicians, we do, a lot of things that are off-label when we decide that the benefit, outweighs the risk. So in our clinic, we have about 4 patients who are younger than 18-year-old that have started pre-exposure prophylaxis. They are between the ages of 16 and 17. And what we have done is that we have obtained parental consent for treatment, which is required, for any minor that is receiving any treatment beyond STD treatment, family planning service, or substance abuse treatment in our state. But that consent has been obtained 2 times, over the phone. We have talked to the minor, and the minor has given the telephone of the parent, and we have talked to the parent over the phone, explaining what happened. I think the issue around disclosure of sexual orientation is an issue that goes beyond, the 18 years, since, many, young adults remain in the parents' insurance up to age 26. And there's always, I always tell my patients, if they are on the parent insurance, that there is a possibility that the insurance company will send an explanation of benefits, to their house, saying that they were in the doctor. And we kind of work with them, trying to prepare them how to manage that situation if that will happen. But we have seen multiple times where patients who are on PreP have to stop taking PreP because the parent is not supportive of them being on PreP. It's part of practicing in an environment that is very conservative, where many parents believe, that children, or their children should not be having sex until they're married, and they impose, their will in many of those patients.
Okay, great. All right, so I don't see any more questions. Again, we've seen some requests for material, so if our speakers could send us some materials, we'll get them out to everybody. A couple of take-home messages that I got today was that, I think PreP, not only from an HIV prevention point of view, but, if dispensing PreP and then making sure that people are screened every 3 months if possible can really help reduce STD prevalence. So I think, all programs should really think about what role they have in the cascade. If you don't have an STD clinic, or you don't have the resources, there's other things that you can do in identifying high-risk clients and linking them up to PreP, and then making sure that maybe working with providers and making sure that patients are getting screened frequently. So we really appreciate all the great presentations today. At the end of this, you'll get a quick link to a SurveyMonkey, 6 or 7 really brief questions. we really need some help with evaluating these webinars, and also gives you an opportunity to suggest topics for future webinars. So I really want to appreciate our speakers for taking all the time and getting presentations ready and times out of their busy schedule. We apologize to our friends on the West Coast and the Pacific Islands for the early start. We looked at like 30 different days and times, and this was the only time that we could get all 3 speakers. So again, if you have any technical assistance needs, make sure you talk to NCSC or CDC. We've given you your numbers, and we will get these materials out to everybody. So everybody have a great afternoon, and we'll see you and talk to you on the next webinar. So thank you.
Okay, thanks.